I would like to thank you in advance for viewing this module and hope you find it useful for more active participation in lab. My goal after this module in lab is for you to be able to draw connections with prior coursework, identify which patients and when are classified as benefiting from exercise, and more specifically, the movement control approach. Be able to justify your decision-making for exercise selection based on the ICF framework, current symptom status, and patient goals. Also be able to demonstrate proper patient interaction, including exercise modification, progression, and feedback strategies, as well as to discuss readiness for progression into more difficult exercise versus progression to the functional optimization category versus discharge. To appreciate where we are today, I want to give you a glimpse of where we came from. We will begin with Panjabi's three-system hypothesis. In the early 90s, Panjabi hypothesized that spine stability is a function of an active system consisting of muscles, a passive system consisting of non-contractile tissue, including intervertebral discs and ligaments, and a neural system. The job of the active system is to control spine stiffness and allow for coordinated movement between spine segments. The job of the passive system is to provide structural stability as well as provide proprioceptive input. The job of the neural system is to process information from the active and the passive subsystems to determine output required, what we term motor control. Dysfunction in these subsystems may require adaptive mechanisms of other systems to improve movement and reduce tissue injury. This explanation can be found in Kistner and Colby, Chapter 15. Figure A demonstrates a healthy system where the neutral zone of a spine segment is depicted as a bowl with the sides representing passive structures and the ball representing segmental mobility. In Figure B, we see a consequence of injury where there is more segmental mobility allowed and less support from passive structures. Figure C shows how training segmental muscles may help control for excessive segmental mobility. Next, we have Bergmark's proposal of local and global muscles. This slide should look familiar. The stabilization exercises you learned in Foundations will set the stage for exercise prescription of the spine. Recall, we have both local and global muscles. Local muscles include the transverse abdominis, lumbar multifidus, and in the lumbar spine, specifically the pelvic floor and diaphragm. These muscles are made up of mostly type 1 muscle fibers and are proposed to help control a neutral joint position as well as control intersegmental mobility. In painful states, these muscles tend to underfire. The global muscles include the quadratus lumborum, rectus abdominis, obliques, erector spinae, latissimus dorsi, and gluteus maximus. These muscles are mostly made of type 2 fibers and in painful states tend to overfire. This figure is taken from Kistner and Colby, Chapter 14. It shows that if we have an isolated activation of global muscles without activation of the intersegmental muscles, there is risk for deformation due to compressive loading. With attention to these segmental muscles, Hodges and colleagues began studying their form and function in patients with low back pain. They found that those in pain, both due to injury or experimentally induced pain, had changes in local muscle structure and function. Specific to the lumbar multifidus, they found a decreased cross-sectional area and fatty infiltration of the muscle. Looking at function, they found a delay in the activation of the transverse abdominis noted with extremity movements, as well as poor endurance. Their conclusion was that pain and injury created poor local muscle performance, which decreased the stiffness of the spine and increased the susceptibility to deformation, shear forces, and thus more pain. This was exciting stuff. Pain caused poor muscle performance. Who better than us to improve performance of these muscles? So we started to look into what effect addressing these muscles would have on pain and function, and what we found was unfortunately shocking. First, these impairments may be more of an effect of back pain versus a cause, meaning isolating treatment of these muscles may not improve pain. Also, size has not been shown to matter. The size of the lumbar multifidus does not predict those who would benefit from stabilization exercises, and improvements in pain have not been found to be associated with a change in lumbar multifidus thickness. And finally, performance of these muscles are not predictive of who will do well with stability exercise. There are weak associations between baseline characteristics and future outcomes. In fact, changes in activation tend not to be associated with corresponding changes in clinical outcomes to date. That may be because we need to address more than just these muscles when prescribing exercise. McGill had that same belief. He has demonstrated the importance of training local and global muscles, and that for some patients, cueing for correct movement versus cueing a specific muscle leads to better outcomes. McGill believes that all muscles stabilize the spine and we need a balance of these muscles. He found that delays and other impairments occur in most muscles of those with low back pain. He also notes that the activation of the transverse abdominis in isolation is nearly impossible and may in fact delay a patient's progress. He also rocked the boat with finding that bracing may be superior to the abdominal drawing maneuver currently being used in research. He proposes using a variety of exercises to address all muscles and planes of movement, and has identified these 3 exercises as being necessary in the prescription for most individuals with low back pain. He states that no one muscle contributes more than 30% to spinal stability. So that brings us to the present date. What is the current best evidence guiding our exercise prescription? To date, no approach has been shown to be superior. This could be because the groups studied are too heterogeneous and exercises are based on protocols versus the individual patient needs. Our question then becomes, who would benefit from what exercise and when in their plan of care? We can look to our clinical practice guidelines, a clinical prediction rule by Hicks et al., and our most recent update of our treatment-based classification system to answer this question. According to our clinical practice guidelines, individuals classified as having a motor coordination impairment should be prescribed exercise. Individuals fit this classification if they report recurring episodes of low back pain, present with aberrant movements, have pain during initiation or mid-range movements, and/or have pain with provocation testing. We may also look to a clinical prediction rule proposed by Hicks et al. They found 4 factors favoring stabilization exercises, including age less than 40, straight leg raise greater than 91 degrees, the presence of aberrant motion, and a positive prone instability test. If patients met 3 or more of these factors, they had a positive likelihood ratio of 4 for a positive response to exercise. This CPR was unfortunately not validated. However, during the validation study, a 2-factor rule was found. If patients present with aberrant movements and a positive prone instability test, they have an 80% chance of improvement with a specific stabilization exercise protocol. It is my personal opinion that this number may improve by appropriate exercise intensity and progression to more functional activities. Moving to the most recent update of the treatment-based classification system, we find the individuals with moderate levels of disability, stable symptoms, and low to moderate pain may benefit from the movement control approach. One important thing to note is that patients that once were classified as symptom modulation can and likely will progress towards this category. That means patients with high irritability that have improved to low irritability after your manual therapy, directional preference, or traction can now be classified as movement control. We can use this schematic to guide what our patients need in this category. If they have residual mobility deficits of the spine or surrounding joints, you may continue with exercise to improve mobility. You may also begin to prescribe exercise for muscle performance, or what this group calls global stability. Within global stability, we want to address the activation and motor control of muscles in isolation and then progress to acquisition, where they use this activation during simple tasks such as limb loading. And finally, we want to train assimilation, or the ability of these muscles to properly perform during more complex tasks, including ADLs, IADLs, and other functional tasks. To make this new information more comfortable, let's look at a familiar document, as these activities will carry over to this lab. I would also like to present this schematic to you, as this is what you were exposed to in foundations, and overlay where this new terminology fits in. The activation of stabilizing muscles you practiced in FI lab is called activation and acquisition. The integration into functional activities you practiced is called acquisition and assimilation. And finally, the muscle performance you learn in FI is similar to assimilation and functional optimization, which is another category of the TBC which we'll address shortly. I would like to also recall this figure from your prior coursework. Remember, with exercise, we have several goals and impairments to address, and this will carry over into our lumbar spine exercise prescription. I would like to make a quick point about how exercise addresses pain. One way is through controlling intersegmental stability. Another way is to decrease protective muscle spasm. If the erector spinae are in spasm or are reacting to overuse, we may immediately decrease their pain by encouraging relaxation through the transverse abdominis ability to hold a neutral spine. This has been a lot of information so far, so where do you start? One way is to use the ICF. Consider the health condition and if there is a tissue or a range of motion you must protect. You have also learned how to assess for the activation of the transverse abdominis and lumbar multifidus. For review, please refer to Chapter 16 in Kistner and Colby. If the patient is unable to activate these muscles, this is where your exercise prescription starts. The next step is to assess for the patient's acquisition abilities or their ability to dissociate movements. This is similar to the limb loading strategies you practiced in foundations. Other suggested ways of assessing acquisition is through an active straight leg raise, a prone hip extension, a prone hip rotation, and an active hip abduction and sideline. If the patient is unable to maintain a neutral spine with these activities, it becomes your treatment. When your patient demonstrates competency with these items, it's time to address these specific activities and their ability to hold a neutral spine and activate the correct muscle patterns throughout. Here is another guide for how to dose and progress your patient. This can also be found in Chapter 16 of Kistner and Colby. They propose you begin with an exercise that the patient can do for 30 to 60 seconds until they accomplish approximately 3 minutes. Then add difficulty or intensity and decrease the duration again until the patient can perform the activity for 1 to 3 minutes. You may also begin to consider removing postural support and feedback. The spine is not exposed to the demands of gravity in supine or prone. It is not exposed to gravity in quadruped. However, quadruped does not receive feedback from the floor regarding spine position. Next is kneeling, where the spine is introduced to gravity and does not receive feedback from a surface. There is, however, less joints and muscles to coordinate in kneeling versus standing. Note that you can take advantage of external feedback by standing against a wall. We also want to consider making exercises more difficult by adding multiple limbs and multiple planes to coordinate. I also want to point out that there will be a time where you will want to train movement control of the spine versus only training in a neutral spine. I think we do our patients a disservice if we do not train out of neutral, as functional demands typically take us out of neutral. One final point to make is considering if your patient presents with a directional preference. If your patient prefers extension, you may want to start with exercises that encourage more spine extension, such as quadruped limb loading. Once your patient has progressed through the movement control category, you are now faced with the decision of discharging or progressing towards functional optimization, which is where we see more strength and conditioning occurring. This is all based on patient goals and activity requirements. We are unable to address this category specifically. However, I point you to selecting exercises based on the endurance and strength testing you learned in exam and eval, and that which I have included in both the lab document as well as the YouTube channel. I also encourage you to observe and train plyometrics, including throwing and catching. I conclude this module with a few clinical pearls. First, avoid assumptions. I have been fooled many times by patients telling me they have tried core exercise. Many times I find they are training incorrectly. Always remember to watch your patients first. Provide one cue and then manual facilitation if required. Also note there is overlap. You may use the same exercise in different patients to accomplish different goals. Also, base your progression off of your patient's performance versus a fixed timeline. And lastly, always consider regions above and below the spine. Thank you for hanging with me through this module. I hope it lays the foundation for better understanding and participation in lab. Looking forward to seeing you then.